Hello, everybody. Thank you for listening to my presentation. My name is Joseph Jabor. I'm a PGY3 emergency medicine resident at Henry Ford Macomb. My case report is an interesting one. Wernicke encephalitis as a sequelae of COVID-19, titled Dyschezia-Induced Nutritional Deficiency. So just give a brief overview of the case. Wernicke encephalitis, it is usually associated with alcohol use disorder and caused by a deficiency in thiamine. Classic findings include confusion, ataxia, ophthalmoplegia. This case is a unique presentation of Wernicke encephalitis in a 14-year-old female related to prior COVID infection. The patient actually ended up developing dyschezia as a sequelae of her initial infection, and as a result of that, stopped eating and therefore developed thiamine deficiency. She had presented with confusion, ataxia, and changes in speech. She had a very prolonged and complex hospitalization, which we'll get into a little bit here. And then she ended up having an inpatient rehab facility as where she was ultimately discharged to. So overall, the case, it's very interesting. And it basically serves to at least expand your differential when you have a patient presenting to the emergency department who has a history of COVID-19 infection with altered mental status. So just really quickly here, I'm just going to go over the case. You had heard that she had COVID-19, then had dyschezia, and then had a presentation to the emergency department with these neurologic changes and findings. So initially, she had a CT scan, vital signs, laboratory testing, et cetera, all of which was negative. And she was actually admitted for encephalopathy. And after about 1 day of being admitted, neurology was consulted, an MRI was done, which showed possible acute disseminated encephalomyelitis. She was started on high-dose steroids at that time. Her clinical course had abruptly changed within the next 24 hours. She had neurologic failure and hemodynamic collapse, where she came then to the pediatric ICU, and that is where I was working at the time. She was intubated because she was not tolerating her secretions and ultimately was hypotensive and was started on pressors. She had an EEG done at that time, did not show any type of epileptiform activity. Echocardiogram was normal. So she ended up being treated further because there was no change in her mental status, and this was even off of any type of sedatives. She was then initiated a second MRI, which did reveal findings consistent with Wernicke encephalitis. We did a thiamine level for her, which was found to be significantly low at 20, with a normal range typically between 70 and 180. And that's when the parents were further questioned about her diet, oral intake, and they said over the past 3 weeks or so, she was not eating anything except maybe a few saltine crackers a day because she had such a foul taste, which they said that she had expressed prior to her or after her infection. What was very interesting, I just want to quickly touch base on the MRI findings consistent with Wernicke, which I have listed in my poster there. We have the medial vestibular nuclei showing symmetric hyperintense lesions. There are symmetric high signal intensity alterations in the facial nuclei. The tectum of the midbrain and the paraaqueductal gray matter that has very high signal intensity. And then lastly, something that we may remember from medical school lab was the mammillary bodies bilaterally, which show signal intensity alterations. And her MRI showed all of those findings, which were consistent with our diagnosis. So overall, very interesting case. Again, just serves to expand our differential when a patient presents to the emergency department with altered mental status, history of COVID-19 infection. Very rare to see this presentation in children in the pediatric population, typically something associated with alcoholics, which makes it also something very interesting. Thank you for listening. Please let me know if there are any questions.